ST segment starts at the J point, the junction between QRS complex and ST segment, and ends at the beginning of T wave. ST segment is isoelectric and should be level with PR and TP segments. ST segment may have slight upward concavity, or may be slightly elevated or depressed, usually by less than 1 mm. ST segment represents the interval between ventricular depolarization and repolarization. The most important cause of ST segment abnormality, ST elevation or ST depression, is myocardial ischemia or infarction. ST elevation is significant if there is at least 1 mm or 0.1 mV elevation in a limb lead, 2 mm or 2 mV elevation in a precordial lead, in relative to PR or TP segment. This criteria has a false positive rate of 15 to 20% and a false negative rate of 20 to 30%. Differential diagnosis of ST segment elevation or transmural acute myocardial infarction, coronary vasospasm or Prinzmetal's angina, benign early repolarization, pericarditis, left bundle branch block, ventricular paced rhythm, ventricular aneurysm, Brugada syndrome, and increased intracranial pressure. Acute ST elevation myocardial infarction may reveal ST elevation with either concave, convex, or obliquely straight morphology. ST segment elevation and Q wave formation in contiguous leads can be observed in acute STEMI. There is usually reciprocal ST depression in the electrically opposite leads. In this EKG, ST segment elevation in anteroseptal leads, V1 to V4, Q waves in septal leads, V1 and V2, and hyperacute T waves in V2 to V4 can be observed. This feature indicates acute anteroseptal ST elevation myocardial infarction. For more detail, watch videos related to each STEMI topic. Prinzmetal's angina due to coronary spasm causes ST elevation, very similar to acute STEMI, with localized ST elevation and reciprocal ST depression that occur during episodes of chest pain. It is not possible to differentiate these two conditions based on the EKG alone. Unlike acute STEMI, the EKG changes are transient and reversible with vasodilators, and not usually associated with myocardial necrosis. Benign early repolarization causes mild ST elevation with tall T waves mainly in the precordial leads. Benign early repolarization is a normal variant, may be seen in young healthy individuals younger than 50 years of age. It is also known as high takeoff or J-point elevation, and may mimic pericarditis or acute myocardial infarction. EKG features that are more likely to be seen in benign early repolarization include ST elevation at the J-point with concavity, notching of the J-point, with fish hook pattern, diffuse ST elevation with concordant prominent T waves with large amplitudes, normal R wave progression, and relative stability from one EKG to another. However, ST changes may be more prominent at slower heart rates, disappear in the presence of tachycardia. Benign early repolarization should not be diagnosed in elderly individuals, older than 50 years, or in patients with significant cardiovascular risk factors. Acute pericarditis causes widespread concave saddleback ST segment elevation and PR depression in multiple leads, typically involving leads 1, 2, 3, AVF, AVL, and V2 to V6. There may be reciprocal ST depression and PR elevation in leads AVR and V1. Downward sloping of TP segment, known as Spodek's sign, may be observed in acute pericarditis. In left bundle branch block, prolonged QRS complexes, deep and broad waves in S waves in right precordial leads, and notched R waves in left precordial leads may be observed. Moreover, ST segment deviations and T waves are directed opposite to the QRS complex. In this figure, in leads V1 to V3, dominant S wave produces ST elevation and upright T waves. In leads V5 and V6, dominant R wave produces ST depression and T wave inversion. In patients with left bundle branch block, diagnosis of myocardial infarction can be difficult based on EKG. The Sagarbasa criteria is used in the diagnosis of an acute myocardial infarction when a left bundle branch block is present. Ventricular pacing causes ST segment abnormalities, identical to those seen in left bundle branch block. There is appropriate discordance, with the ST segment and T wave directed opposite to the QRS complex. In left ventricular hypertrophy, EKG changes may show ST elevation in the leads with deep S waves, usually V1 to V3, ST depression and T wave inversion in the leads with tall R waves, leads V5 and V6 in this figure. Left ventricular aneurysm formation is a complication of acute STEMI, causes persistent ST elevation on the EKG. This EKG is obtained from a patient with previous myocardial infarction. Deep Q waves, ST elevation and inverted T waves can be observed. This pattern suggests the presence of a left ventricular aneurysm due to a prior anteroseptal myocardial infarction. The characteristic EKG findings in type 1 Brugada syndrome are partial right bundle branch block, a cove-type ST segment and T inversion in leads V1 and V2. Brugada syndrome is a disease of myocardial sodium channels, associated with paroxysmal ventricular arrhythmias and sudden cardiac death in young individuals. Rare causes of ST segment elevation include pulmonary embolism and acute cor pulmonale, acute aortic dissection that causes inferior STEMI due to right coronary artery dissection, ST elevation secondary to QRS widening due to sodium channel blocking drugs, increased intracranial pressure, hypothermia, hyperkalemia, hypercalcemia, following electrical cardioversion, cardiac tumor and myocarditis. Now, let's focus on ST depression. Causes of ST segment depression include myocardial ischemia, effect of digoxin, secondary to repolarization abnormalities in right or left ventricular hypertrophy and bundle branch blocks, hypokalemia, and secondary to tachycardia. The most important cause of ST segment depression is myocardial ischemia due to coronary artery disease. Dynamic ST segment and T wave changes favors myocardial ischemia. ST depression can be either horizontal, downsloping, or upsloping, but horizontal or downsloping ST depression more than 0.5 mm at the J point, in 2 or more contiguous leads indicates myocardial ischemia. ST depression more than 1 mm is more specific, and associated with a worse prognosis. ST depression more than 2 mm in 3 or more leads is associated with significant mortality. Upsloping of ST depression is nonspecific for myocardial ischemia. However, upsloping ST depression in the precordial leads and tall, prominent and symmetrical T waves, associated with de Winter T waves is considered to be a STEMI equivalent. Additionally, most individuals present ST segment elevation, 1 to 2 mm in lead AVR. De Winter pattern is highly specific for acute occlusion of the left anterior descending coronary artery. Posterior myocardial infarction manifests as horizontal ST depression in V2 to V4, associated with upright T waves, and dominant R waves in V2, which is Q wave equivalent. ST depression can be seen as a result of reciprocal changes in acute myocardial infarction. For example, in acute inferior myocardial infarction, ST segment depression may be seen as reciprocal change in leads 1 and AVL. Treatment with digoxin causes downsloping ST segment depression. The presence of digoxin effect is not a marker of digoxin toxicity, it indicates that the patient is taking digoxin. The classic digoxin effect appears as a downsloping ST segment depression, also known as the reverse tick or reverse check sign. In right ventricular hypertrophy, right ventricular strain pattern with ST segment depression and T wave inversion in V2 to V5, dominant R wave in V1 and dominant S wave in V6 can be observed. Right bundle branch block may produce a similar pattern of repolarization abnormalities, with ST depression and T wave inversion in right precordial leads. Hypokalemia causes widespread downsloping ST depression with flattened or inverted T wave, prominent U waves, and a prolonged QT interval. Supraventricular tachycardia may also cause widespread horizontal ST segment depressions, most prominent in left precordial leads, V4 to V6. ST depression is rate-related, and if ST depression resolves with treatment, it does not necessarily indicate the presence of myocardial ischemia. I hope you enjoy this video. Thank you for watching this video. Stay safe and healthy.